Hi, I am Dr. Felice Gersh, your integrative OBGYN. For this segment, and I think this will interest a very large number of my followers, we're going to talk about endometriosis. Endometriosis is not a rare condition. It affects between 10, even up to 15% of women, predominantly during the reproductive years. And the impact that endometriosis has on a woman's life is enormous. Well, what is endometriosis? The name comes from endometrium. That's the lining, the glands that line the uterine cavity, and these glands are supposed to stay in the uterine cavity and not grow elsewhere. But, and I'm going to touch on this, they do grow elsewhere throughout the pelvic cavity, even sometimes distant, far-flung places, but we'll focus on the most common, which is growing within the pelvic cavity, outside of the uterine cavity. So let's talk a little bit about some of the symptoms, and then we'll go into some of the theories on etiology. The symptoms can be life-changing. Women with endometriosis typically have a great deal of pelvic pain. This pelvic pain can be chronic, in other words, continuous, many days, regardless of having a period. It can also be very exacerbated during the menstrual cycle and often for a week or two preceding the onset of bleeding, what we would call severe menstrual cramps or dysmenorrhea. Typically, it is secondary dysmenorrhea, meaning there was a time period when the woman who has this condition had menstrual periods without severe pain. But we now know that actually there is a certain smaller percentage of women that can have terrible cramps related to endometriosis right from the outset of having periods. So what else? Well, you can have very severe pain with intercourse, what we call dyspareunia. This pain is usually a deep kind of pelvic pain, not like an irritation within the vaginal canal, but deep, like something is being hit, like really deep onset of pain. In addition, because of this chronic ongoing pain, the neurological system that supports the sensory, the sensations of the pelvis becomes like activated. So in addition to having pelvic pain related to the periods or with the uterus or the endometrial implants directly, many women who suffer with endometriosis will also have irritable bowel syndrome, a lot of cramping, discomfort involving having bowel movements, just crampiness in the GI tract. In addition, they have higher rates of interstitial cystitis, now named burning bladder syndrome, which is also an unexplained condition of women where they have symptoms like they're having a bladder infection, but on testing, they do not have any growth of any sort of bacteria. And over time, they can even have ulcerations that develop within the bladder itself. Women with endometriosis often typically will have a great deal of emotional distress, lots of anxiety and depression. They will have infertility. Infertility is extremely common in women with endometriosis. And what's interesting is that even a small amount of endometriosis, almost a few specks, can actually also be associated with very severe pain, very severe symptoms, and infertility. So sometimes it seems like it's really out of proportion, the amount of pain relative to the findings. And how do we diagnose endometriosis? That is a problem because there right now is no really easy way. There are people, researchers, looking for markers, blood markers or urine markers that can help us identify women with endometriosis. That's not yet become established. So now to make a definitive diagnosis, you need a tissue biopsy. That would require doing a laparoscopic surgery. Typically, it can be done elsewhere with an open surgery, but typically nowadays it's laparoscopic, and that would be an invasive surgery. Even though it's a small surgery, it's still invasive, requiring puncturing the abdominal wall in multiple sites and having general anesthesia. So when that is done, when a laparoscopic procedure is done, small tissue biopsies can be obtained, and you can also have visual identification. But the ultimate gold standard is a tissue biopsy diagnosis. Nobody wants to do surgery if not necessary. And now it is acceptable to make an assumption based on the symptoms and sometimes physical findings that a woman has endometriosis and then treat the endometriosis. You can now, using MRI, ultrasounds, by the way, will typically not show endometriosis unless you have big masses, like a big endometrioma on the ovary. An endometrioma is endometriosis implants on the surface of the ovary, which causes bleeding, and this bleeding causes the accumulation of blood, creating a big cyst filled with old dark blood, which we used to call, sometimes still, a chocolate cyst. That is an endometrioma. Let's get down to more what endometriosis is. It is the implantation of uterine lining glands, the endometrium, in somewhere in the pelvic cavity. The most common locations would be behind the uterus in an area we call the cul-de-sac. So it's like a little indentation, like a little dip area behind the uterus, between the uterus and the rectum. That is the most common area. In addition, on the ovaries is another common area, and on the surface of the bladder and other surfaces of the peritoneum, the sort of glossy lining that encompasses the entire surface, inner surface of the abdominal cavity, is called the peritoneum. And on that smooth, sort of silky surface, you can have implants of these endometrial glands. If you look at them with a laparoscopic surgical procedure, they look like bluish black little blobs, is really how you would say it, like you had splatter. And some of them would be a little thickened, some would be kind of flat, but they have a bluish black look. They can be red and they can even be clear. So it's not 100% this sort of bluish black look, but that's the most classical look. And when you see them on a laparoscopic surgery, they can be ablated. That means they're sort of destroyed using typically a laser, or it could be a cautery to destroy them, or they can be excised. Now, these endometrial implants can go very deep into the ligaments that are behind the uterus, called the uterosacral ligaments, and that can cause a great deal of pain. There are some surgeons who will do very extensive excisional surgeries of the endometriosis to try to cut out all of the endometrial implants, which can go very deep. They can dig deep and burrow deep into the pelvic area, into the areas near the ureters, near these big nerves, near these big ligaments. And so the surgeries themselves are fraught with danger, because you can have significant injuries and future scar tissue from these surgeries. They sometimes are successful in relieving pain and allowing a woman to not end up having surgery that involves excision of her female organs, because what's called definitive treatment would be to have all the female organs removed: the uterus, the cervix, the fallopian tubes, and the ovaries. And that, of course, is an extreme thing to happen in young women, reproductive aged women, but it does sometimes happen. Sometimes just the uterus will be removed. The ovaries are left behind, and that can relieve a lot of the pain related to having a period, because there are no periods without a uterus, but there can still be other kinds of pain, and some of those women will go on to have additional surgeries down the road. But of course, they can never carry their own babies at that point. And many women who have infertility with endometriosis will undergo IVF, in vitro fertilization, and they do work, but not all the time, not by any means. So it can definitely offer hope for women. Because of these endometrial implants, they will often, as it gets worse and worse, develop scar tissue, which can damage the fallopian tubes and even block them, increasing when they're not fully blocked, the risk of a tubal pregnancy, an ectopic pregnancy that lodges in a fallopian tube, even an ovarian pregnancy where an embryo implants on an ovary can also happen. These can be, of course, devastating for women who have been undergoing infertility treatments and they end up having to have a pregnancy ended because it cannot be possibly viable because it's in a fallopian tube or on an ovary. So how does this even come to be? Well, like in most things, there is some degree of genetics involved, but it's more than just that. There's a genetic tendency, and we don't know 100%. It may be more than one reason why it happens, but there is more mounting information and data that it relates to endocrine disruptors, chemicals in our environment that alter the function of progesterone receptors. So the progesterone, that vital life hormone that's produced after ovulation in the ovary and sets the stage for pregnancy and other things that I'm going to tell you about right now, the receptors for that hormone are not functioning properly. So you don't get the proper effects that you need to prevent the development of endometriosis. So how is this potentially happening? Well, when you look at the menstrual cycle, that will give you some idea of how this could come to be. When you have a cycle, when you have a normal, physiologically appropriately functioning, reproductive age woman, in the first half of the menstrual cycle, which day 1 is the first day of bleeding, that's by definition, during that time, during the first 2 weeks of a 28-day cycle, there is production of estradiol, the estrogen the ovaries make. And this level of estradiol rises, and then you have a giant spike up of the estradiol, which triggers a giant spike up of luteinizing hormone. That's a hormone produced by the pituitary gland. And that triggers ovulation. And with the advent of ovulation, the follicle that put out the egg is transformed into what is called a corpus luteum. That structure is now designed to make progesterone. And you get quite high levels of progesterone in the second half of the menstrual cycle, called the luteal phase. Or for the uterine lining, we call it the secretory. But regarding the ovary, it's called the luteal phase, the second half, the last 2 weeks of a 28-day cycle. Now, during that time, a very interesting thing happens involving the immune system. Okay, so what's going on? Well, assuming a pregnancy does not happen, the progesterone levels drop. But even before that, during the luteal phase, there's an interesting effect of the high levels of progesterone on what? On the endocannabinoid system. The endocannabinoid system, which you may only have heard of when you hear the word cannabis. Well, cannabis is a plant that has molecules that is coming from the plant that actually combined to our own receptors for the endocannabinoid system. The endocannabinoid system, which is in our bodies, is a system of signaling agents that are fatty acids derivatives from omega-6 fatty acids. So these are lipid signaling agents. And these are very, very profoundly important in reproduction. The receptors for the endocannabinoids, and there are 2 major endocannabinoids, anandamide and 2-AG. And then there are sort of like cousins. But these ones, the main ones, they have receptors CB1 and CB2, and these are dispersed throughout many organ systems in the body, including on all the immune cells, particularly the innate immune cells. These are the first responders to an invading pathogen like a bacteria, a virus, and so on, or injured or damaged tissue. And the endocannabinoid system has receptors on the immune system. They also have receptors in the uterine cavity involving the endometrium and the muscle of the uterus. They also have receptors in the GI tract. Throughout the body, there are many different sites of receptors. And it's very critical to have the proper amounts at the right time of these endocannabinoids. There are also receptors on the ovaries, on the fallopian tubes. It's just all over the reproductive system. These signaling agents are very regulated in a back and forth. It's bidirectional interaction between the endocannabinoid system and the reproductive hormones. We'll focus on estradiol and progesterone. Well, it turns out that a peak of endocannabinoid production occurs when you have that spike of estradiol that precedes and then ultimately is part of the initiation of ovulation. It turns out when you have high estradiol, it downregulates the production and it increases the enzyme that degrades the endocannabinoids. So basically, as estrogen drops after you have that big spike, so too does the endocannabinoids also drop. They peak with the peak and then they drop. Progesterone also decreases the production, the receptor function in certain places. It's very interesting. It can work differently on different organ systems in different places. Well, it turns out that when you're in the second half of the menstrual cycle, the luteal phase, the levels of endocannabinoids are very low. They must stay low. If a pregnancy occurs, they stay low all the way through the pregnancy until you get to the induction of labor when they spike up again. And you need to keep them low. Well, these endocannabinoids, as I mentioned, have receptors on the immune system. They help regulate the onset and the stopping of the inflammation reaction. When you have high levels of progesterone in the luteal phase, at second half of the menstrual cycle, it upregulates the receptors for the endocannabinoids on the immune cells. And what that does is it primes them to be calmer so that they don't explode with inflammation. And why would they explode with inflammation? Because when you have a menstrual period, you have shedding of the uterine lining and it comes out the vagina. But in virtually every woman, some of it goes backwards through the fallopian tubes, and that dead and dying tissue and blood enters the pelvic cavity. And that is called retrograde menstruation. Now, you have dead and dying and yucky tissue coming into the pelvic cavity. The immune system reacts to that if you don't have the proper priming of those immune cells via the endocannabinoid receptors, which are primed by the high levels of progesterone to keep those immune system cells from going crazy and exploding with inflammation response with this dead stuff coming back from the fallopian tubes. So that is what happens when you don't have proper progesterone function. And the receptors on the immune cells for progesterone are not working properly. You don't get the proper priming for the endocannabinoids. And the endocannabinoid system at that point is very low in terms of the numbers. So what you do have circulating has to be extra efficient, and it's not working. So basically, we can call it the brake system of the immune system is not working. So the immune cells explode with inflammation in the pelvis when that dead, yucky stuff is coming backwards out the fallopian tubes. That explosion of inflammation triggers the production of estrogens in the pelvis because the enzyme aromatase is in the pelvis. It's in many places in the body, and it is turned on like to high mode by inflammation. So inflammation triggers a local production of estrogen. And then this estrogen is being sort of hijacked to do things that it would not normally do because estrogen is about creating healing. And what part of healing is creating growth factors to grow and nurture. So the uterine lining is nurtured by estrogen to grow. That's called proliferation. Well, now you have inappropriate production of estrogen in the pelvis that's creating stimulus with growth factors to grow the endometrial cells, the uterine lining cells that are coming out the fallopian tube. So instead of the immune system properly and effectively gobbling up and dealing with these dead cells coming out the fallopian tube, it explodes inappropriately with an excess of inflammation, creating all this excessive estrogen that is promoting growth factors, and then you end up having the growth and nurturing of these endometrial cells rather than their destruction and cleanup crew working properly. So over time, every time you get a period, you get this explosion. Pain is always involved with inflammation. You cannot have pain without inflammation. Okay? So now you have the setting for severe pain, inflammation, and with all this inflammation and pain, it creates this sensory overload that then can alter the immune cells and how inflammation is throughout the whole body. You end up this chronic sort of inflammatory state. It's also been shown that through their stress and so on, and they have this dysbiotic gut microbiome, which leads to leaky gut, which further exacerbates the problem by once you have leaky gut, you have endotoxins from in the gut coming out into the body, which then further upregulates these immune cells to be crazy. Progesterone is very anti-inflammatory, and that is critical for keeping inflammation down during a pregnancy so that these immune cells don't kill and destroy a fetus. But now when the progesterone is not working properly, you have uncontrolled inflammation, which is always a product of immune cells. So that's why some people call endometriosis a condition of mast cell activation. The mast cells are the first responders of the immune cells to create an inflammatory response. So you get upregulation of the sensory neuron system that creates this chronic sense of pain that can involve the bladder and the colon and the pelvis. And then women will often contract their pelvic floor muscles because of all the stress. And then they get myofascial pain, pain of the muscles and the support system of the pelvic floor. So it just goes on, and inflammation then creates neuroinflammation, which can lead to mood disorders. So what do we do about it? Well, the conventional approach is get rid of menstrual periods, get rid of the hormones. And there is something to that. If you shut down the whole system, the ovaries are not working, you're not having menstrual bleeding, you're not having retrograde menstruation, you can have dramatic reduction of pain. And that's what they do. They basically give drugs to shut down the whole system involving the brain and the pituitary, and that goes down. And then you won't have any periods, but you also won't have any hormones. So that's a problem. So you really will pay a price in the long run because you basically get rid of a woman's cycles and you get rid of a woman's hormones. Another way is to block the enzyme aromatase to convert the androgens into estrogens in the pelvis. And that is also a reasonable idea, but then you don't make estrogen anywhere. So you're not going to have any estrogen in the body at all. So that's a problem. So the price to be paid for the conventional therapies is that you have a young aged woman who basically has no hormones anymore. And there's really a lot of problems associated with that. They always have warnings about you get osteoporosis, but that's not all. You're going to have all the problems of hormonal deficiency states, like when you're really young. So that is a big problem. And of course, you're not going to have fertility. So those are really significant problems. So what can we do? I'm not saying that those therapies are not appropriate in some situations. And surgery is also appropriate in some situations. Not curative, but sometimes is necessary, especially if you have a big endometrioma. You've got to deal with that. Well, what can we do? Well, anything that we can do to lower inflammation and to lower endocrine disruptors. I mentioned endocrine disruptors. The most common are pesticides that are involved with this progesterone dysregulation of the receptor function. Pesticides, the one that has the most data is dioxins. So pesticides are a huge problem. Organic food and an anti-inflammatory diet can be really, really helpful. Mind-body medicine that can actually help lower stress will help lower inflammation. So just simple lifestyle things, they call it like the endometriosis diet. High plants, antioxidants, polyphenols, vitamins, minerals can actually dramatically improve the status of a woman's situation with endometriosis. And sometimes giving higher amounts of progesterone can help to override the progesterone receptor resistance. So there is no magical solution, but lifestyle medicine with exercise and stress reduction and an anti-inflammatory diet and using targeted supplements like quercetin and absorbable curcumin, these anti-inflammatories, specialized pro-resolving mediators, all these things that lower inflammation can actually have a significant impact. Magnesium even will be very beneficial. Boswellia can be helpful as an anti-inflammatory agent. So don't underestimate also the use of cannabinoids like CBD, because as I mentioned, now we're not talking about someone who is pregnant, because you would never give any kind of CBD product, and certainly not a cannabis product that has THC, to a pregnant woman, because you got to keep all the endocannabinoid system very low during pregnancy. But in women who are not trying to get pregnant, they're not pregnant, we're just trying to deal with the situation, there's actually data that giving CBD as a suppository to get it up inside, or also orally or under the tongue, can be beneficial to activate those endocannabinoid receptors on the immune cells. Quercetin, which is a mast cell stabilizer, can also be very beneficial. So certain targeted supplementation, an anti-inflammatory lifestyle, lowering pro-inflammatory stress signals, like keeping cortisol at appropriate levels, working on adequate sleep. These are not insignificant benefits to women with endometriosis. They're not going to make big implants disappear. They're not going to cure an endometrioma. But for early stage endometriosis, these can be amazingly beneficial. So I hope that helps with some of the complex nature of endometriosis. It's not a simple condition, not well understood by anyone, but we understand it better now than ever before. Thanks for joining me.